11 a.m. here on Q100.7 FM. And coming up is going to be your Pulse radio show, telling you all about the QEH. The Pulse radio show brought to you with the compliments of MedSafe Medical Supplies Limited. They offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and more. They're conveniently located on Gemmett's Lane, just a 2-minute walk from the QEH. And for your convenience, they deliver free to the Queen Elizabeth Hospital. They're open Monday to Saturday, 8:30 a.m. until 5:30 p.m. and you can give them a call at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials. And let's speak a bit more about some essential medical care. And let me say a very good morning to Shane Sealing.
Good morning, Andrew, and good morning to all listeners here on Q100.7 FM, and welcome to another edition of the Pulse Radio Show. So good to be with you. I'm feeling really good today. I have to welcome my new co-host, the Chief Operations Officer of the Queen Elizabeth Hospital, Dr. Christine Greenidge. No stranger to most of Barbados. You've seen her at the helm over about 2 years or so, making sure that the institution maintains its course and improving patient care across the board. She now is definitely looking at all operations, fine-tuning what is being done there, including in the accident and emergency department, which is run by head of department Dr. Anne-Marie Cruickshank, who is back for another edition because we know that you want to know everything that is happening with your accident and emergency department. It's your hospital, it's your AED. Welcome, COO. How are you doing this morning?
Good morning. I feel very well this morning, and good morning to all of our listeners. We are excited to be with you again this Monday morning and to listen to your questions and provide some answers.
And we love to do that. And this radio show, came out of something, a concept which was actually created by our Chief Operations Officer. So we had the Pulse newsletter first, which you said to me, Shane, I want a newsletter done. And you gave us the title. We executed. And then it stemmed and it grew into what is now this radio show, where we could better connect with our listeners, with our public, to let them know not only what we're doing at the QH, but how we can better serve them. Talk to us a bit about yourself. This lady from St. Philip, Barbados.
One of the best parishes in Barbados. Yes, I was born here in Barbados and left as a child. Lived in New York City from childhood up until 2 years ago when I retired early from the New York City Health and Hospital Corporations. And part of my early retirement was to come back here where I was born and nurtured, and to share my experiences of over 35 years in healthcare. And so far, it has been a wonderful journey. I am very, very, very focused on the health status and states of Barbadians and look forward to sharing more information. But I think, Shane, and for all of our listeners, it's so important that we get the information out there to help our public be able to better care for themselves and, of course, their families. And the name Pulse for our newsletter and ultimately the growth of this particular show is that, I regard the QEH as the pulse of the nation in terms of its stellar commitment to healthcare.
Indeed. And speaking about communicating with the public and getting the information out there to them, we were definitely doing that this weekend. If you go on our Instagram page, our social media pages, you look at those media reports coming from right across the media, especially here at CBC, about our medical team responding to the surge in patients in the accident and emergency department. So communications would have sent out this notice guided by Dr. Cruickshank and her team, of course approved by the CEO and the COO for the operations there. Dr. Cruickshank, welcome back. The public were demanding that you make a second appearance to tell us all that is happening in the AED, and I know when they see this, they will have a lot to say because since I took up the job at the QH, this is something that we've been trying to do, let people know what the status is in the accident and emergency department. Why, in your instance, that you thought it was important that we go this route?
Okay, first of all, good morning, Shane. Good morning, Dr. Greenidge, and good morning to Barbados. It's important that the public know what is going on in the AED so that they are guided as to whether they should come for their medical treatment or they should use another facility that can give similar treatment depending on their medical condition. So it's always important to update the public when we have a patient surge. And we had that on Thursday last week, leading into the weekend.
Okay. COO, and I mean, this is something that we've been doing from time to time, alerting the public about those numbers. For me, I always thought that this is a good way to let people know not only that things are a bit busy in A&E, because you have those surges, then you have those times up to recently, we had like 7 patients waiting to be seen and the waiting time was 15 minutes.
Yes.
And then you have times when you have 52 patients waiting to be seen, like Thursday, and the waiting time increases because you're using the same pool of resources.
Correct. It's very important that from the standpoint of activity in the A&E, that we let the public know that this is what is happening here and now. It gives them the choice in terms of looking at alternative means of getting the assistance that they need. But most importantly, we do not have a choice in the A&E. Whoever comes through our door, we have to be seen. In other countries where there are multiple hospitals, there's a system called diversion. We don't have that luxury. So we can't say that you can't come here to go there. So it becomes very important that we keep our public aware of the activity, and that's updated periodically as we focus on decanting the number of patients in the A&E. But how is that affected? For example, I think 2 weeks ago, Dr. Cruickshank emphasized the different categories of patients that present in the A&E. And therefore, if we get an influx of trauma, for example, of typical, especially in the last couple of days, gunshot wounds, cutlass wounds, stabbing wounds, gaping wounds, these are dire life and death situation, which then we have to refocus and redirect our clinical staff to get to these very, very, very urgent attention that these patients need.
Yeah. Dr. Cruickshank, speaking about that, what is the situation like now? I know we had the peak of just over 50 patients on Thursday, and day by day your medical teams work hard right around the clock to bring that down. What is the status now?
So this morning there were 19 patients at 8 o'clock waiting to be seen,
Okay.
and those were divided into 17 category 3s. I would remember 2 weeks ago, as Dr. Greenidge said, those are the urgent. They make up the majority of patients that we see, and we had 2 category 4s, which are less urgent. So we're not doing too bad at the moment in terms of the patient surge. We've overcome that.
Good. And one thing to note, I heard you mention, we normally have a meeting every morning to update about what is happening at the hospital. So all the departments meet every morning for just over half an hour to just get a status update. And this morning you reported that there were some patients in the hospital, in AD, who were there because they simply didn't take their medication.
Yes, this is one of the category of patients that we see, patients who have chronic diseases, non-communicable diseases, who are non-compliant with their medications, and then they present to the A&E with complications of those chronic illnesses, and that does put a strain on our resources. So therefore, we encourage persons to comply with the advice given by their medical practitioners to take their medications, so you do not have to come to the A&E to put added stress on the other patients that we're trying to manage.
Yeah, we want you to manage your health. And I know this is a pet peeve for you, Dr. Greenidge.
Yes.
People not taking the medication when they're supposed to, prescribed by a doctor. You've been given instructions and you decide, you know what, I feel good today, so I'm not taking my medication.
Yes, and let's just focus on one particular category of medications, and that is medications for high blood pressure, hypertension. The second category will be medications for cardiac disease and or the diabetic medications. So when patients present with these out of whack, pretty much out of whack, out of the normal limits of a blood glucose level and or a blood pressure reading, it becomes a problem. And when we investigate, the nurses, the doctors, they do their assessment, the patient would say, I ran out of my blood pressure medication. How many days? Oh, last week. So these are typical, and what happens is that the blood pressure is measured based on the continuation of the adherence to that medication. And in particular, I want to focus in on males in particular, because of some of the side effects of this category of medication. They tend not to want to be compliant. So we want to emphasize self-management of your illness. Your doctor will prescribe these medications for a reason. So the important thing is that just about a week or so before you look at the number of the pills that you have in your container, if you're approaching less than 7, which means that if you take one a day, you need to get your reordered fill. And I want to take a moment to really advertise and promote our home drug delivery service. Mm-hmm. These medications can come to you at least a week in advance so that you never ever run out. And the importance of taking your hypertensive medication to avoid strokes. And we know that as a nation right now, we are looking at this phenomenon in terms of the number of younger people that are having strokes, and it's really of great concern. Indeed. So I'm an advocate, yes, for self-care and for self-management.
And being proactive. And we want you to be proactive today and call us at 434-1007 or 434-1070. Remember, you also have that WhatsApp option. You can send us a message at 434-1007. But it was important for us to set the scene for today's discussion as we are focusing again on your accident and emergency department. On the first show we had, you heard the second episode of the Pulse Radio Show, Dr. Cruickshank. We barely got through, a long laundry list of things that happen in the accident and emergency department, all focused on patient care, making the patient a priority. Where do you want to go next?
Well, we had touched on input last time, which dealt with registration and triage. I think we should move to throughput, which is the next part of the AED flow. And in the throughput, you're now, having been initially seen by the triage nurse and gotten initial investigations, etc., medication, bloods, etc., you're now ready to be seen by the doctor, right? And the doctor will now interview you, will take a history, will examine you, and may do some additional investigations or additional treatment to come to some sort of assessment or what we call a working differential diagnosis. And from there, once they've gotten that, they've gotten all back, all the investigations have now come back, they then will decide if you need to be referred to a specialty or if you can now be treated and discharged with referral to your private or polyclinic doctor or coming back to the A&E review clinic. So essentially, you're now within the A&E proper and you're now waiting now to be seen, I should say, by the specialties.
So it's almost like you're getting traffic directed.
Yes. I tend to think of it as a conveyor belt. And once you start the conveyor belt, you go along to the various stops in the A&E until you get to the end, which is the output, which is disposition, either admitted or discharged with a plan.
Indeed.
I just want to add, because I really want to break down this information for the public. So how can you help our A&E doctors when they come to interview you? They're doing a history of you, your medical history. These are very important from the public standpoint. Out there, everyone, listen carefully to what I'm about to say. Know your history. How long have you been a diabetic? Know the names of the medications that you take and the frequency of when you take your medication. And most importantly, the last time that you took that medication. Now, I tell people very simply, some medications have very big ridiculous names. We know that. Write things down. Everyone has a cell phone. You can create your own little profile on your phone and your own personal app and write the names of your medications. These things are so important to help the doctors expedite seeing you and getting that assessment that is critical to throughput.
And one other thing, they could also take pictures of the bottles, the medication they have, and just show the doctor, well, look, this is what I'm using.
Yes, I've seen so many times that, I take this yellow pill, this yellow tablet, and I take it in the morning, but they can't articulate the name. It helps the doctors to really understand your current presentation as well as what will need to be done in your throughput aspect of being in the A&E. So again, number one, write down your meds, keep a little file. Ladies, you walk with 2 and 3 pocketbooks, have a piece of paper there with the names of these drugs, how frequently, and the last time that you've taken things.
I know you've been waiting on the lines, callers, to get in on the Pulse radio show to ask Dr. Greenidge or Dr. Cruickshank some of your burning questions, some queries you may have. So let's welcome in the first caller this morning. Welcome to the Pulse radio show. What's your question or comment, caller?
To all.
Good morning.
How are we doing this morning?
You want me to be honest?
Yes, please.
I'll be honest with you. The West Indies hurt me last night.
They also hurt me too.
They nearly sent me to A&E. Dr. Cruickshank nearly had to deal with me last night. But I will say to all West Indian fans, the guys looked, what I saw is that they looked like they had some fight in them and they were trying the best. This isn't some of those West Indies teams that we would have seen over the last 15 to 20 years that just rolled over. Even though they got a subpar score, they tried to fight. And I like what I'm seeing from this West Indies unit under the coaching of Darren Sammy. So I think better things are to come. It just wasn't for us this time around. But I know you have a question that you may want to ask Dr. Cruickshank or Dr. Greenidge.
Yes, I do. I agree with you. I'm not a cricket fan, but, everybody can win.
Right.
That's the problem. Everybody can win. So cheers to the best person that does. Anyhow, going back to the doctors, I'm here sitting listening to your program. I'm actually enjoying every single comment that you made. Update, actually. But one update I'm not actually hearing, right? Is a little concern of mine. Have you curved the problem of persons coming and leaving the elderly there and just leave them there without anybody collecting them back? Have that problem been solved out?
Well, caller, I want you to pause there, right? Even if you have another question, because...
No, I don't have another question.
The COO has been chomping at the bit to really speak about this and let the public understand what is happening with a phenomenon we call elderly for care.
Yes.
And then there's young for care.
Yes. Caller, thank you so much for this concern. It is quite concerning. It's a concern at a national level, but most importantly, it's a concern for us here at the Queen Elizabeth Hospital, in particular the A&E. So this is a scenario, and it's a shame. As a child growing up here, I remember in my communities that when someone reached that wonderful age of being a senior, everybody took care of that person in the community. And but our society has changed in terms of that value structure. So what we see on a daily basis is sometimes it is very periodic. It's episodal. So we're approaching crop over. This is one of the seasons in which we see an increase or an influx or insurge of elderlies being brought to the facilities and literally left there. And unfortunately, caller, some people will say that I can't take care of grandma or grandpa or mom or dad anymore, and they don't come back. Sometimes they give us incorrect numbers. Sometimes they blatantly tell us that we are not coming back. So they become now a disposition state in that our goal as they come through the A&E, we must stabilize them. But once they're stabilized medically and they're stable medically, they become a disposition problem in that they now are dwelling and taking up what we call acute care beds in the facility because they have no place to go back home to. Now, mind you, when we look at the data of this particular elderly for care, many of these are coming from their own homes. The majority of them have families who have unfortunately disbanded them. But here's the thing. as we have Asian parents and grandparents, it is time for families to get together and discuss, future states of how we're going to handle the care, the ongoing care that grandma or grandpa will need. It is not being in an acute care facility such as the Queen Elizabeth Hospital.
It really do pain me.
Yes.
Honestly. And the thing is, right, QEH have a brand name. Once upon a time when you fill out on a form and ask you where you're born, people are supposed to say Barbados, but no, they say QEH.
Yes.
You understand? So it's a brand name. And we got to live up to that brand name, helping people, helping our own. And you're all doing a great job, though, by the way. So continue and keep it up, huh?
Thank you so
very
much.
Caller.
Thank you. You have a
Appreciate it.
great day.
Thank you. You too.
Dr. Cruickshank, maybe you can explain before you get to the next point with Annie, how the elderly for care phenomena affects your department.
It affects the department in that we have to still provide care for the elderly for care. As Dr. Greenidge rightly said, we're an acute care facility. So when we have to stop now and go through the elderly for care and go through their treatment and examine them and make sure they get their medications and they get their meals and the nurses have to tend to them and bathe them, that is not what the A&E is set up for. That's for the ward. So we have to now get a doctor who should be seeing the acute care to go and see the elderly for care. And they're actually taking up beds in the A&E, which should be for acute care patients. So it does put a strain on the limited resources that we have for the acute patient.
Yes, and that's why we're appealing to the public generally, your families, and Dr. Greenidge clearly stated it. You have to have those conversations so that you can ensure that your loved ones are taken care of where they're most comfortable,
Yes.
which is at their home. And
I
go
have
ahead,
to
Sierra.
share this. This happened to me about a year and a half ago. I went up to one of the wards and I had a conversation with one of the elder for care, and this person cried. And they said to me, I have a house, I have a home. I want to go home, I want to go home. And it pains myself, it pains the staff. And I have to say at this moment, I applaud the staff at the Queen Elizabeth Hospital, in particular our nurses. These men and women provide the loving care to these elder for cares. And at any given day, our census of elder for care and young for care can exceed 45 patients. And that equates to 2 acute care beds that are otherwise occupied by people who are stabilized medically but have nowhere to go. So a social services department work in partnership with our geriatric facilities to try to place them as quickly as we can.
Yeah, and if you want some help in getting your loved one out of hospital, or just some help in guiding you to know what to do to help that loved one out of hospital where they can be in a more comfortable space, you can always call our patient relations department, the patient advice and liaison service. That number is 536-4800. You call and they will give you some advice and some guidance as to how to get that patient who is considered and deemed elderly for care out of hospital into their own comfortable setting at home. You have another point, Dr. Cruickshank?
Yes, I do understand that family members, it is a strain and a stress to take care of the elderly, but we can help you. You don't have to abandon them in the A&E. Our social worker can assist you in terms of getting assistance from the National Assistance Board. We can help you to place them in the geriatric hospital if there is space. We have the district hospital if there is space. And we have medical practitioners who have specialized in geriatric care, who can then be referred to that doctor for assistance to help with Alzheimer's or senile dementia. So do not feel that the A&E is the place for your elderly for care. We can assist you to place them in the correct facility.
Yeah, the seasons we see this a lot, as Dr. Greenidge mentioned, Christmas and crop over.
Yes.
When people want to get out and do their own thing and they're saying, I may not be in a position to take care of my relative and enjoy myself, but you have to change that focus and focus on these people that made sure you are where you are today. I know, Dr. Cruickshank, you have a hit list here of things happening in the A&D. What's up next on the menu?
Well, we touched on throughput, but I guess we can go straight to output. which is the disposition of the patient. Now, as I said, we then refer the patient to the specialty. And the specialty will come and see the patient, may have to do further investigations, will re-examine. So patients always say they have to go through the same things again, but the specialties have to take the history again, re-examine, may have to do further investigations, and will then confirm or negate if this patient is for their particular specialty.
And there may be more than one John Brown.
Correct. So yes, that is one of the accreditation requirements, that we always start off with what is your name and what is your date of birth, that we are speaking to the correct John Brown.
Exactly.
So patients get a little bit peeved, but we have to do it. It is part of accreditation that we're always dealing with the correct patient at the correct time.
Yeah, we got to make sure that we cross our T's and dot our I's, Dr. Greenidge.
Yes, and it's part of something we call patient safety. And don't forget also that sometimes there may be challenges with memory in some of the patients, so we want to make sure that we are providing the right care to the right person. So don't get a little bit annoyed if you're asked repeatedly your name and your date of birth. It is to protect you and also our staff.
Let's go back to the phone lines. We have another caller there. Good morning. Welcome to the Pulse Radio Show. I'm not rushing the program at all. It is still morning. What's your question or comment, caller?
Good morning, sir.
Good morning.
Good morning to your guests. Good morning to our listeners.
Good morning.
I just want to know, when you go to the polyclinic to get a catheter change, that the doctor's going to do it, and not the nurse, and there's only about a 5-minute procedure, and you got to sit down and wait. I got sometimes 2 hours, 3 hours, and the nurse is there, and they could do it, but the doctor's got to do it. Why is that?
I know that is the current practice at the polyclinics. I know at the QEH and A&E, we are now trying to change that practice, in that our nurses are now trained to change catheters. So I would hope that in time, the nurses at the polyclinic will also be able to be trained to do that procedure, because it's not something that only a doctor can do. Nurses can do. Nurses, they catheterize females, but I know initially it was a little bit taboo for them to catheterize males, but that is now changing. So currently in the A&E, our nurses can catheterize male patients. So I do hope with time the nurses at the polyclinics will be able to catheterize male patients also.
And just caller, for an FYI for you, the QEH does not dictate the operations at the polyclinic. That is dictated by the Ministry of Health and Wellness. So the QEH and our Board of Management and our medical teams govern what happens in our space at Martindale's Road. But the polyclinic is out of our purview, but they help us, and they help guide some of that traffic away from A&E, especially some of those Category 4s and those Category 5s that need less urgent treatment.
Yeah, because that's why because I usually send us to them. That was a polyclinic.
Yes.
So
Yes.
I go there because I used to only come at the hospital before Smith and Scott went 24 hours,
Yes.
Well, I've been blocking the day. I used to go to the polyclinic.
Yes.
But when it was night time, at the hospital, too, the nurse at the hospital do it. I think that's why I asked the question. When I used to go to the hospital and I block, the nurses organized me money going.
Yes.
A long time at all.
Yes,
Yeah.
that is
Yes.
very correct, sir. Very, very correct at the hospital.
The
nurses do it.
And I always say this, and either of you can correct me if I'm wrong. When you come to the hospital, you're in your worst state normally, especially when you're presenting to A&E. And I say to people, sometimes you have to wait, but it is to wait for treatment that can save your life. Others can't wait because they may be trauma victims, may come in as Category 1s and 2s. They have to be seen by a number of medical teams immediately to save their lives. You, as a Category 3 or 4, may have to wait a bit longer, but ensure that and be sure that our doctors, our nurses, our PRRs, which is our patient relations reps, our medical staff, in its entirety, they will get to you to make sure that when you can leave our hospital alive. Sometimes there will be negative outcomes, but the majority of times there are positive outcomes, and that's what we are trying to achieve at our hospital and right here on the Pulse Radio Show. Let's take a quick break here for a commercial and be right back.
I wanted to.
For all your medical supply needs, visit MedSave Medical Supplies Limited. They offer a wide range of products, including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and more. That's right. Conveniently located on Gemmitt's Lane, just a 2-minute walk from the Queen Elizabeth Hospital, and for your convenience, they deliver free to the Queen Elizabeth Hospital. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Give them a call at 624-7542. MedSave Medical Supplies Limited, your trusted source for medical essentials.
Yes, and you're getting the pulse of the QEH right here on Q100.7 FM CBC Radio, the place where we want you to be every Monday from 11 to 12. Of course, they have a slew of programming here on Q100.7 FM. Very interesting stuff. I always got to salute my good friend, the Admiral, who's on mornings. And shout out Kimberly and Andre, too, who helped to pull this program together. COO, you were very happy to hear that comment and question from the caller.
Absolutely. I want to applaud that he is actually utilizing the healthcare services that's appropriate for his condition, and that is namely tapping in on our partners in the polyclinic. So good for him.
And he understands. He's
Yes.
not urgent. I don't need to come to the AD.
Absolutely.
When he is urgent, he will come to the AD to receive the requisite treatment, which falls under this laundry list of things that Dr. Cruickshank is responsible for along with her medical teams. What's next, Dr. Cruickshank?
Right, so we're at output now, and as I said, the specialties come down to see the patient. If the specialty has decided that, yes, this patient needs to be admitted under my specialty, they will then put on the notes, admit, be it internal medicine, surgery, urology, orthopedics, etc.
Because I was going to ask you to explain what are the specialties.
Right, so all the subspecialties will now will see and put at the front note, admit, under their respective specialty. And after that, the next team comes into play, which is bed management. Bed management is the team that admits the patients to the respective ward that belongs to the specialty. And they will only admit if they see that magic word, admit, written on the notes. And they are a dynamic team that come and try to place the patients to the respective ward, because they know that certain wards offer certain specialties, and the nurses on those wards are trained to manage those respective specialties. So that is where we reach to bed management. Now, if you're not admitted, you are discharged. But you can have a discharge plan in that you're discharged to see the specialties in the outpatient clinic, and we will give you a referral letter to make an appointment at the medical records. You can either be discharged back to your polyclinic or private doctor, and we give you a discharge summary to go back to the doctor, or you come back to the A&E review clinic, which is Monday to Friday, 8 to 12, and you're seeing one of the consultants in the A&E. You're also discharged with your medication, your prescription, which you can get from the pharmacy or have the home delivery send that to you. You have your discharge letter, as we said, your NIS paper, because you may need time home from work, and you may have to get your back to work, back to school letters. So there's several things that you have to get when you are discharged from the A&E, and we ensure that you understand clearly your discharge plan if you are discharged.
We got to say good morning to Monique Edwards, who I know is tuned in, our bed manager. She is responsible for managing that situation, making those discharges where necessary, and just controlling the flow through the Queen Elizabeth Hospital. Let's go back to the phone lines very quickly. Good morning, caller. Welcome to the Pulse Radio Show. Do you have a question or a comment for us?
Yes, good morning to the panel. My question is three things. If that these three people had to admit to casualty, there's a cancer patient, heart patient, and kidney patient. Will they be able to be seen as emergency?
So let's get you the answer for that question first, Dr. Cruickshank.
No.
Yes, I really was going to direct it to her.
Right. Remember what we said, the input involved triage. Triage is where the triage nurse interviews each patient and deals with objective and subjective information. So subjective is getting the history from the patient, and objective is getting vitals and other information. So depending on what the presenting complaint is, the nurse will decide which triage category that patient falls. So for example, a kidney patient might come into heart failure because they're in fluid overload. That's a category 2. They have to go straight into the resuscitation room in order to be treated for the fluid overload. Cardiac patient may be having a heart attack. Once again, they may have to go in the resuscitation. And the third category, cancer, depends too. That cancer patient may be now at end stage, may require palliative treatment, or may be having a complication of the cancer. So depending on what the presenting complaint is, the patients are treated accordingly, and they're treated the correct way. So that is very important, yes.
That's what I want to know, because in what I'm using this on, there are 3 people that in my category that have those things. So I know, like, you have in the heart, as you say, sometimes you get fuel and so on and so on. That's what really make you sick. And I know you has come in there already, you know, and you're over really sick. And so I want to know if anything change up now, or you would come like an emergency to be seen. That's all I was asking.
Correct. That is a type of emergency. Because remember, everything is an emergency, but there are different levels of emergencies.
What's your next question, caller?
I don't think I got any more, because them is the 3 things I worry about, because them is, as I said to you just now, them is the 3 people that I just got the DV.
Okay.
One is cancer, one is heart, and one is kidney.
Well, you know, if you need any help in dealing with these patients, 536-4800, your hospital
I got
pal.
it right down there. A book, let me see if I got it right.
Okay, 536.
Hey, hold on, let me open the drawer first. Check out the book.
Alright, open the jar, take out the book, boy.
I work out right here. 536.
4800. Huh?
536.
48.
Right.
00.
Right, 4800. Okay, after 536, 4800. Okay, thank you.
No problem, not a problem at all.
Yeah, all right, dear. Bye-bye.
We're always glad to help. What's next on the laundry list, Dr. Cruickshank?
Well, I think patients ask why it is that you wait so long in the A&E once you've been admitted. And sometimes, unfortunately, because of the number of admissions we have, the beds may not be available. So you may have to stay in the A&E, but bear in mind, you're being treated in the A&E. Your specialty is still coming down to see you. Your treatment card is still written. The nurses are still managing you as if you were on the ward. When that bed is available, you are transferred immediately to the admission bed. So that's important to know, that although you may not have a bed right away, your treatment is being done in the A&E.
Mm-hmm.
Really have to emphasize that point, because many times what we hear is that Miss So-and-so has been in the A&E for 2 days. The fact is that that person have been triaged, have been assessed, have been started on treatments, but the problem is that I have no acute beds to put Miss Smith in.
Because you might have too many EFCs.
Too many EFCs, just a surge of patients, discharges not reaching the number that we need to accommodate those that are newly admitted. The emphasis here is that although the person remains physically in the AED, they are getting their treatment. Treatment has started. They're being seen by the nurses. They're being seen by the doctors. It's just that we need to relocate them to the wards.
Talk about how you, as Chief Operations Officer, have been looking at the flow to best manage and see how we can make sure that patients get the best treatment and that we get them to be discharged in a manageable, or what we see as an appropriate time.
Yes, very important that we look at our processes from the door through what we call disposition. So think of D&D, door to disposition. And disposition could be discharge, it could be referral back into the polyclinic system, but most importantly for us, disposition to the wards, meaning that the person has been admitted. So all the processes between the door and disposition are continuously under quality review in terms of our metrics, right? We have certain targets that we must meet, or we're striving to meet. But in between machine, get it into that bed, we're going to make sure that the tests are completed and we get results. We want to make sure that the diagnostics, sometimes it's an x-ray or it could be also a CT scan, that we get those results back so that the doctor can make that definitive decision as to whether or not this person needs to be admitted. So it's a continuous goal that we strive in terms of always, we're never comfortable, and we should never be comfortable in terms of our processes, because we always need to improve them.
Can't rest on our laurels at all.
Patient experience is very, very important.
Priority for us at the QEH. The CEO always says every patient matters and every staff member counts.
Absolutely.
And that's what we try to promote as far as patient-centered care is concerned. Remember the numbers to call: 434-1007, 434-1007, and that can also be used as WhatsApp messages as well, for WhatsApp messages. And you can also call 434-1070. Let's go back to Dr. Cruickshank. You had a list of things that you really wanted to use as a guide to help the public understand patient flow and movement in the AED.
So we outlined input, we outlined throughput, we outlined output, and we said that sometimes the beds may not be available and you may have to wait. But I would like to probably explain what we do for patient surges, because recently we've been having quite a lot of patient surges, and I think the public needs to know what that entails for us in the AE.
I know the public gonna always ask this: why are we having these patient surges, and like what are some of the conditions presenting to AED that would result in more than the normal number of people coming to seek that emergency care outside of like an accident or an emergency, one of those trauma cases?
Well, as you rightly said, the NCDs, the non-communicable diseases, and the complications of those take up a lot of our times. And because Barbadians are living longer, a lot of our patients are over 65. It's amazing. I would say like 50 to 60% of the patients we see daily are elderly. They're over 65. And an elderly person has more complications. We have to go from head to toe because we don't want to miss anything. They cannot verbalize exactly where the pain is. They would just say they have bad feels. So the doctors and nurses have to be very, very astute when they take the history, when they examine, and therefore they would need more investigations. And as a result, they take longer and they take up more of the resources.
The question that you pose has to do with surges and some of the common things. So, for example, lately, what has been happening in Barbados? It's been very, very hot. Extremely hot. And now we're talking about the majority of our patients being elderly, so they're prone to be dehydrated. So we're seeing a lot of people coming in dehydrated states. So the education here for the public, we know it's hot, the body reacts to simple water. Water. And in the elderly population, often they hesitate to drink water because they don't want to have to be in a situation where they have to go to the bathroom continuously. If they're traveling out there, let's say going into town or just doing their routine chores, please, with this heat, walk with a bottle of plain water. Keep yourself hydrated. It's so important. And when elderly become dehydrated, they need to come in to the AED because we're going to run what we call a drip to rehydrate the body so that their electrolytes, the body fluids and electrolytes, maintain that delicate balance so that they don't become ill. So when we talk about surges, sometimes it not only non-compliance, for example, in taking their medications, but something as simple as just this recent onset of heat. And our younger people are complaining. Shane, you complain of the heat. It's hot.
It's hot.
It's very, very hot. So we have to look at our clothing. We have to look at our hydration state. We have to look at our feet, very important as well, because when it's hot, feet become dry and cracks, and then it leads to other complications as well.
Listen, we gotta really, that's something that I know you also want to focus on right here on the Pulse Radio Show. So in the coming weeks, we'll get into a lot of talk about foot care and how that affects people living with diabetes and other chronic non-communicable diseases.
And I want to add to what Dr. Greenidge said. The elderly they may not be able to verbalize that they want water. So they're very easy to get dehydrated. So you actually have to give them the water, and you may have to assist them to drink. They're also on medications which can cause them to become dehydrated or constipated. They're also sedentary. They're not moving around. So they are a category of patients that require a lot of care and attention when we have to look after the elderly in the A&E.
I want you, before we go back to the COO, because I know she wanted to jump in there as well, to paint a picture for the public of what it has been like trying to reduce the surge this time around.
Right. So from around Thursday last week, we had 52 patients waiting to be seen. As soon as I see over 40 waiting to be seen, I spring into action. There's certain things that must be done when I see that magic number. And immediately we have to let Dr. Greenidge and Mr. Clark, the CEO, and the Director of Medical Services know we are now in a patient surge.
So 40 is your magic number.
I use that as my cutoff point. When I see that number of patients to be seen, waiting to be seen, I have to let my superiors know what is going on in the A&E. Right? And from there, we then inform them. We also have to see if we can bring in any additional staff to help us with the surge. We have to let bed management know that we need to start getting the discharges, and the admissions in the A&E have to go up to the ward to free up beds. Discharges from the wards have to be done safely so that we can get more beds. So the consultants of the specialties need to know that they have to do their ward round and safely discharge their patients. We also have to let our 24-hour clinic know that we may need help with the category 4s. So we will call across and tell them we'll be sending category 4s to you for assistance. And we also have to let the PALS desk know you're going to have to step up because you may have to work a little longer hours than the scheduled hours.
We would normally extend the hours for the help desk to 12 midnight.
Correct.
So that we can field more callers, get the pulse of the people, hear what people are saying.
Yes, so what Dr. Cruickshank just described is our trigger alert system, where we mobilize all our teams from various aspects with the goal of decanting the A&E, getting patients out through our throughput processes, but also high alert to our partners in polyclinics, to our teams within the facility as well. So the magic number of 40 mobilizes literally the troops, and also get our air traffic controllers targeted to in the direction of getting the patients out.
I like that. Air traffic controllers in the ED.
And don't forget, Shane, you are essential as the communication specialist sending out your public service announcement, because you know when you hear my voice, you know I'm asking for a PSA to be sent out to the public.
This is how I ask you for that. I see the call like, Dr. Cruickshank, hi, how are you doing? And then it goes from there. We put together the message. Of course, the COO, the CEO, they vet what we send out, and then we disseminate to ensure that you, the public, knows what's happening in your accident and emergency department. Let's go back to the phone lines. We have another caller. Good morning, caller. Welcome to the Pulse Radio Show. What's your question or comment?
Good morning, sir. Good morning to everyone. I'm calling about a tumor, tumor in the head. Tumor.
A tumor in the head, yes.
The head, yeah. I had enough. I went on the bed twice. And the hospital.
Yeah, please listen to your the phone and not the radio, my dear.
Okay, me too. Me really ready.
Yeah, turn it off. Don't try to listen to yourself. Just just talk to us and let's answer your question.
Yes. So I was wondering, I get put back regular. So I want to know if the tumor, if I could if I go into surgery soon, or what? I can hardly see with the eye, headache, giddy head.
So, caller, do you have an appointment to see the neurosurgeon in the outpatient clinic?
I get an appointment for the 2nd of July.
Okay, so when you go to see the specialist will decide what date he or she will give you for your operation, and will also have to do some preliminary investigations to prepare you for surgery.
Yes, I get prepared so regular and get sent back.
You got put back.
Yeah,
Okay.
and one thing that the doctors always emphasize, you must listen to them so that when you present for your surgery that you're fit for treatment, that you're
Correct.
fit for surgery. So
Yeah.
please follow the medical advice that the doctors give you so that when you come, that the chance of you getting that surgery is high, that you can make sure that you get that treatment.
Okay, I pray this time it go through.
Yes. And if you have any questions, also remember, I'll repeat this number all the time. 536-4800. You got that, caller?
Yes.
536-4800. You call them and they will help to guide and direct you to ensure that you get the best possible care.
Okay, thanks. I just pray and everything will go this time.
I will
Understand.
pray
We
with you
pray
as
for
well.
you.
Yes, we understand.
Thank you.
Yeah, thanks for calling
Thanks.
and sharing your experience with us here on the Pulse Radio Show. And this is why this avenue is here, so that you can do just that. And we can give you the guidance you need so that when you come to the QEH, it's smooth sailing, or as smooth sailing as possible. You know, you get a little bump, sometimes a little rough seas, but we'll try to make sure that you get dealt with in the shortest possible time, because your time is valuable and we want to make sure that you are seen, treated, and discharged. See, all you wanted to add something?
I just want to tell the caller that the point that you made in terms of the ready state for surgery, and it could be any type of surgery. So many times when patients say that they were planning to have an operation and it was, let's say, deferred to a future date, it has many times in terms of patient reasons why surgeries are canceled, that right now at this time the body cannot really go through that operation. So we need you to, whether it is compliant with medication, it may be weight loss, but just being in a stable condition prior to the surgical procedure is very important, and that increases your chances of a successful procedure.
Yeah, we have about 7 more minutes to spend with you right here on the Pulse Radio Show. And remember the numbers to call, 434-1007 or 434-1070, 434-1070. You can send WhatsApps through 434-1007, Dr. Cruickshank.
So I want to add one more point to our patient surge escalation protocol that Dr. Greenidge outlined: reassessment. So once you send out your public service announcement, we then monitor and see how the numbers are trending, if they're going up or if they're coming down. And every 8 hours, we do an assessment of the situation, and I have to send a report to Dr. Greenidge and the CEO and Mr. Harris, the Director of Medical Services. So normally, we would see a trending downwards as we tell the public what is going on in the A&E. They then start seeking attention in other facilities. Obviously, if they need the A&E, they come, and we would never turn anyone away. But we see that number trending down, and then we can then manage the situation better.
I want to be absolutely clear about this. We're not telling people do not come to the accident and emergency department. That is not what we are telling you. We are telling you, if you come there with a case which is less urgent, you'll have to wait on the other cases that our medical teams are seeing, which are more urgent, which is dictated by the triage system. So we work with you. We want you to work with us and understand that you have options. You have options if you want faster care, if you want to put it that way. So you can go to your private medical doctor. You can go to the 24-hour clinic at the Winston Scott Polyclinic, which treats less serious cases. You have alternatives, especially during the week. Then you have the polyclinics. However, if that is not the case and you're still coming with a less urgent case, you'll have to wait a bit longer than usual during those patient surges, because there are times when the A&E is pretty light and you will get seen in a short time.
Yeah, that
Absolutely.
is very important to underscore, Shane, that we are not saying not to come to the A&E, but we're saying that if you're not certain, you can call the PALS desk. The doctor or nurse will advise you, because it's managed by doctors and nurses who know the medical conditions from the history and talking to you. So they will tell you if they think you should come to the A&E, or if they think you should see your polyclinic or private doctor, or maybe an urgent care facility where you would get the care. But if you're in doubt, come to the A&E.
As Dr. Cruickshank was speaking, and we're talking about the whole experience of the AED, there's one precursor that I feel that is fundamentally important to share with the public, and that is the use of our emergency ambulance services. The EAS bring patients to the AED. And in speaking to them lately, sometimes they get calls that are inappropriate, or sometimes they rush out to a home and then they get there and the call is canceled. So please be sure that we use our EAS system appropriately, because they are the vehicles that physically bring patients to the A&E. And if they are going to a home or in a location and they get there and people say, well, I changed my mind, and or they chose an alternative way of coming to A&E, that is another case out there that they could have brought immediate attention to. So please, EAS is there to provide safe and monitor transportation while you arrive at the AED. And I needed to include them in the whole process of the AED experience.
I'm so glad you did, because the emergency ambulance service 511 is
Yes.
where we'll be going next week as part of episode 5 right here on the Pulse radio show. Because the ambulance service, people have been saying, they may take a bit long to get to the scene, but they're managing multiple calls, multiple scenes, and trying to get to everyone in the shortest possible time. So you don't want to, waste those resources with a call that does not need the emergency ambulance service. Let's go back to the phone lines very quickly. We have our final caller for the morning. Welcome, caller, to the Pulse radio show as we approach 12 o'clock. What's your question or comment?
Thank you. I'm just giving a compliment, and it comes the right time when you're leaving. I want to give thanks to you all. I have seen great improvement at the hospital in these last 2 years, or a year and a half. And you, Shane, you come in as the public relation, letting us know what's going on. We've seen the pharmacy. We've seen a lot of improvement, and I want to thank you all very much for that.
You're welcome. You're welcome, caller.
Thank you.
And the work will continue. The work doesn't stop there.
Yeah, we appreciate it.
We are being managed by our CEO and our COO, and we're being given directions for improvement right across the board for all services at the hospital, right, COO?
And we are seeing it. As a patient that comes regular, I'm seeing it.
Thank you so much, caller.
And I want to also say that with support from the Ministry of Health, Dr. Jerome Walker, our Minister of Health, and all of our colleagues in the Ministry of Health, that we are connecting the dots to ensure that the public get the level of care and the quality of care that they deserve.
Yes, indeed. Any final thoughts from you, Dr. Cruickshank, as we wrap up your second appearance right here on the Pulse Radio Show? I'm sure it will definitely not be your last, because A&E is always a talking point.
Yes, I wanted to put a plug for the ambulance service to lead off from what Dr. Greenidge said. They asked me to tell the public that when they do come to your home, only one family member can accompany the patient to hospital. And similarly, when you reach the A&E, only one family member can be in the room with the patient. So that's important, that yes, you can come, but you couldn't go down into the ambulance. Just one of you can go, and in the A&E, the waiting room can hold the other family members, but only one can come inside with the patient into the treatment room.
Yeah, very quickly before we go, just explain why we try to limit the numbers for family members. I know we did that in episode 2, but just to reiterate that point, why we don't need a dozen family members for one patient.
Because we don't want too much congestion in the A&E. We have a lot of patients in there, and we're trying to reduce the congestion, the stress, and the strain on the staff and everyone. So one is sufficient, and they can then go back out to tell the other family members what is going on.
Dr. Cruickshank, it's always a pleasure talking to you, hearing that nice voice. It really gives us some reassurance that A&E is going in the right direction. And I know you have a little slogan for A&E. Back on track.
A&E back on track in 2024.
Back on track in 2024. My co-pilot, COO, thank you for being here with me today, as I'm on vacation officially. And I'll try to rest for some of it till next Monday. But yeah. COO.
Great to be here.
You'll be here a lot more times, I'm sure. because we got to get the podiatrist up here as well.
Oh, yes, definitely.
I know you hear that.
Oh, yes.
And that's it for today's edition of the Pulse Radio Show. A bit congested here. I'm Shane Seeley. It's always a pleasure to be with you. Next program, you'll have the emergency ambulance service and a whole lot more. We'll be talking about their role in patient care and in making sure that we meet the needs of the public. I'm Shane Seeley on behalf of the COO, Dr. Cruickshank, the head of department in the Accident and Emergency Department, Kimberly Skeet and Andre Earwood, our operators. Thank you for being here with us. Good afternoon.
Pulse QEH radio show brought to you with the kind compliments of MedSafe Medical Supplies Limited. For all your medical supply needs, visit MedSafe Medical Supplies Limited. They offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmitt's Lane, just a 2-minute walk from the QEH. And for your convenience, they deliver free to the Queen Elizabeth Hospital. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Give them a call, 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.